tumors. We have already covered approach to bone tumors in part 1, and in part 2 we have covered benign bone tumors. Now we will cover malignant bone tumors in this part 3. We have divided it into cartilage bone fibrous forming, then the marrow tumors like multiple myeloma, lymphoma, round cell tumors like ewing sarcoma, then miscellaneous like chordoma, and then skeletal metastasis. First is chondrosarcoma. Age is above 30. Location will be long bone metadiaphysis. And malignant features like cortical destruction, periosteal reaction, soft tissue mass will go more in favor of malignancy. Here there is a cortical break, and this is the enchondroma, central lytic lesion, showing a typical matrix mineralization of ring and arc type going in favor of enchondroma, but there is intact cortex here and there is cortical break here which is going in favor of secondary chondrosarcoma. This is a coronal stir image showing cortical break, soft tissue mass. So the cortical break, soft tissue mass, periosteal reactions of aggressive type like Codman strangle, sunburst, and lamellated reaction are the features which go more in favor of malignancy. Then second is osteosarcoma. It is a below 30 lesion. It will involve the long bone metadiaphysis. Then it will have aggressive type of lytic lesion like moth-eaten permeative lytic destruction, wide zone of transition. It will have cortical break, soft tissue mass, periosteal reactions which are of malignant nature, aggressive nature like Codman strangle, sunburst type of periosteal reaction, and rarely it can have a cloud-like matrix mineralization going in favor of osseous nature of the tumor. This is a radiograph showing a metadiaphyseal lesion. It is having a wide zone of transition and moth-eaten type of lytic destructive lesion. Cortical break is there, and there is Codman strangle here. Then this radiograph showing a perpendicular periosteal reaction, soft tissue mass, and cortical erosion. This is a case of actually a paraosteal periosteal osteosarcoma. Then this radiograph showing a typical osseous matrix mineralization, dense ivory type. Then there is a perpendicular periosteal reaction and soft tissue mass here. So it is a rare type, but this is the most common variety, lytic permeative moth-eaten type of destruction with cortex break, soft tissue mass, and it will involve the metadiaphyseal end of the long bones. Then again, the obviously differential diagnosis will be ewing sarcoma. Then coming to the round cell tumor, ewing sarcoma, pinnate, primitive neuroectodermal tumor. It is the second most common malignant lesion in the childhood after osteosarcoma. It will involve relatively early age group than the osteosarcoma, 10 to 20. It will be a metadiaphyseal lesion, and obviously it will show wide zone of transition and aggressive type of lytic destruction like permeative moth-eaten, and aggressive type of periosteal reactions like lamellated onion skin type of periosteal reaction. A skin tumor is a ewing sarcoma of chest wall, and in pinnate there will be more soft tissue component which is extending into the bone. This radiograph showing a lytic lesion with a moth-eaten type of permeative destruction having a wide zone of transition in the immature skeleton. Here we can appreciate the lamellated type of periosteal reaction with a radiolucent line between the periosteal reaction and the cortex. There is no obvious cortical break or the soft tissue mass. Then obviously the differential diagnosis will be osteosarcoma. Even infection can have similar pattern, but obviously the clinical features and the laboratory findings will differ. Then Connective tissue, in that we have fibrosarcoma, malignant fibrous histiocytoma. They will have a non-specific aggressive destructive type of uh, lesion, and this is a shoulder radiograph showing a lytic destructive lesion of proximal humerus with wide zone of transition, cortical break, cortical destruction, fracture, soft tissue mass. Obviously, the differential diagnosis will be metastasis in adult patient. Then coming to the miscellaneous, there is chordoma. It has a two typical sites, occipital and sacrococcygeal. Occipital will have relatively early age group, 30, and sacrococcygeal will have a 50-year age group. Here there is a sagittal T2-weighted image of the spine showing a expansile non-specific soft tissue destructive lesion involving or epicentered at the sacrococcygeal region. And here there is a CT, axial CT showing a expansile lytic lesion, and it can show these typical sequestry in some patients. The typical sites will indicate towards the diagnosis, occipital and sacrococcygeal. Lymphoma, it can be primary bone lymphoma or secondary bone lymphoma. Secondary bone lymphoma is more common. Coming to the age, it is unlikely below 10 year, and the most common age group is third and fifth, sixth decade. Then it will have a non-specific aggressive permeative lytic destructive nature, and the most common sites involved will be red marrow containing bones like the axial skeleton like vertebra and the pelvic bones and the proximal femur humerus. Then obviously the differential diagnosis will be in adult patient metastasis, and in pediatric patient there will be infection, but the clinical lab features will be different. And then other will be ewings sarcoma, osteosarcoma, and ewings granuloma. Leukemia, in chronic adult it will look like a metastasis, and in acute lymphoid leukemia, which will affect the child, it will have a non-specific permeative moth-eaten type of destruction. Here there is a moth-eaten type of lytic destruction of the diaphysis of the tibia with wide zone of transition. There is a periosteal reaction here, and this is the same patient, but it is a coronal T1 image of the bilateral femur showing a soft tissue mass, but there is little cortical destruction, but the marrow signal intensity is altered. Then multiple myeloma, it is the most common primary malignant bone tumor in adult. It is a above 40 lesion, and typically it will involve the red marrow containing sites like axial skeleton and proximal appendicular skeleton. It will have features like osteopenia, punched out lytic lesions in skull, and in vertebrae it will have vertebra plana. And more than skeletal radiograph survey, whole body MRI is more sensitive because more bone destruction is required to be visible on the radiograph. This is a skull radiograph showing a punched out lytic lesions, innumerable well-defined punched out lytic lesions. This is the sagittal T1 images of the spine showing altered marrow signal intensity, hypointensity. This is the normal marrow signal intensity here. Coming to the Langerhans cell histocytosis, Ewings granuloma is more common. It will involve the pediatric patient, most commonly below 10 year. It will involve the axial appendicular skeleton metadiaphysis. In skull, it will have a lytic lesion, but it will have a sloping edge, beveled edge, because of the different or uneven erosion of the outer and the inner cortex, and it will show non-specific but aggressive type of lytic destructive nature like permeative moth-eaten type, and in the jaw it will be the common cause of the floating tooth sign. And vertebra plana, it is the most common cause of the vertebra plana in a child. This is a sagittal radiograph of spine. It is showing this is a flattened vertebra, collapsed flattened vertebra, vertebra plana. And this is the skull radiograph, frontal view, showing the lytic lesion but the beveled edge. You can appreciate here there is an uneven destruction of the outer and the inner cortex, giving this beveled edge pattern. And this is a jaw radiograph showing a floating tooth sign. And this is a diaphyseal central lytic lesion with a moth-eaten or rather primitive type of destruction with a wide zone of transition and lamellar periosteal reaction. Obviously, the differential diagnosis will be ewings sarcoma, osteosarcoma. Then coming to the adamantinoma, it will involve typically the anterior tibial diaphyseal cortex. It will be centric expansile multilocular lesion. It can have a locally aggressive feature, and it involves the second and the fifth decade. This is a typical location of the diaphysis of the tibia, showing a lytic lesion with multilocular. There is a pathological fracture here, and here there are two lesions concurrent in the fibula which go more in favor of adamantinoma. In adamantinoma, there will be on MRI particularly there will be multicentric lesions involving the distant sites as well. Coming to the skeletal metastasis, it is the third most common site after lung and the liver. It has non-specific features, lytic, mixed or blastic type. It can be diffuse or focal. In male, prostate cancer is the most common, and in female, breast cancer is the most common cause of the skeletal metastasis. Followed by that, we have lung cancer, hepatocellular carcinoma, the renal cell carcinoma, thyroid cancer. Distribution obviously will be the red marrow containing sites like the vertebrae and the pelvis and the proximal appendicular skeleton. Distal appendicular skeleton distal to the knee and the elbow are rare. Then to detect the skeletal metastasis, scintigraphy is more sensitive obviously because plain radiograph the lesion has the bone has to be districted to a much larger extent to be visible on a bone radiograph. This is a pelvic radiograph showing osteoblastic multiple lesions involving the pelvic bones and the bilateral femurs. And this is the bone scan showing increased activity in the ribs and around the shoulder, sternum, femur, iliac bone and the vertebral bodies. Thank you very much. So we have covered the malignant bone tumors like chondrosarcoma, osteosarcoma, ewings sarcoma, chordoma, adamantinoma, skeletal metastasis. Thank you very much.